Hello, everybody. Welcome back to the Doc Talk podcast. I'm Dr. Shaz Mamithani.
And I'm Dr. Sheila Singha.
A special thank you to our episode sponsor, Figs. So obviously in our line of work, you kind of live in your scrubs. And if you follow us on Instagram, you probably already know this by now, but we are obsessed with Figs. They're super comfortable, breathable, durable, and they actually fit, which is just a huge upgrade from those horrible itchy scrubs that were status quo for so long. They're super cute and stylish, and you just feel good wearing them, you know?
Like you said, Shaz, we're obsessed. But you know what I love most about Figs? They just get what it's like to work in this field. It's not just that they know what we need, like 7 pants pockets to carry our stuff around. They also build this incredibly supportive community of people who want to have important discussions and make real connections with other people who work in healthcare. I went to an event today, actually, and it's so refreshing for a brand to show up in such a real way. And you guys, if you're not following them on social media, the memes. If you work in healthcare or know somebody who does, Figs is it. And right now, if you go to wearfigs.com and use code FIGSCA, that's FIGSCA, you can get 20% off your first order. That's wearfigs.com, code FIGSCA.
So today we're actually going to change it up a little bit of a throwback to our perimenopause episode in season 1. If you haven't listened to that one already, please do. But there's so many questions that both Sheila and I get from our followers, from our listeners about menopause and perimenopause. Many of you are women. And what I actually did on my story leading up to this recording is to ask all of you what questions you have for Dr. Sheila, because today is going to be an episode of me just throwing rapid fire perimenopause and menopause questions all at Dr. Sheila. So I'm really excited because the last time we had this episode, I learned so much, and I know that I'm going to learn so much from you again this time.
Well, I'm thrilled because I feel like all I talk about right now is perimenopause and menopause. It's become a big part of my practice. I got my certification in menopause care after many years of not feeling very comfortable doing this care because I'm of the generation of doctors who were taught not to ask, not to treat, because there were some large-scale studies that were interpreted and applied to a population that they shouldn't have been. And so what happened overnight, Shaz, in medical school was that we were told, don't ask, don't prescribe. And that really shifted how care is done for women in perimenopause and menopause for the last 20 years. And there's been such a rapid shift right now in terms of the public outcry around getting support, acknowledging that the symptoms of perimenopause and menopause are real and have significant impact on function and relationships and careers, on how we see ourselves, that it's actually a really exciting time to do this work because we have many options available, and it is my favorite part of medicine right now to do care of women in midlife because I see them before they get that support and acknowledgement, and then I get to see them afterwards, and it is remarkable to see the difference. I
love that. And so I had dozens of questions. I tried to kind of group them all together. Many of them were about HRT or hormone replacement therapy. That is not something that I think we can do in a rapid fire format, but we are going to talk about it this episode just at the very end. So we are saving the best for last. So make sure to listen to the entire episode because there is nuance in HRT that I really want to get into the details with you about rather than just having it be rapid fire. So the first question I have for you, and you kind of alluded to this when you were just speaking, it feels like, I mean, we're talking about menopause and perimenopause a lot more, but it feels like it seems to be a reason for everything. So how much of what we are experiencing is actually from perimenopause and menopause versus not?
Yeah, that's a great question. The pendulum has fully swung, right? So because we weren't asking and acknowledging it, we never brought it up in our medical settings. But people would often say, I just don't feel like myself. I am not sleeping well. My periods are changing. I am exhausted. I have hot flashes or night sweats. I have brain fog, and they have all these symptom complex, and we wouldn't sort of see this as possibly being perimenopause. And if we step back for a moment, just in terms of like what perimenopause is and what menopause is, Shaz, menopause is when you've gone a year without having a period. And then after that time, it's one day that you've gone that full year. And then after that, you're in postmenopause. And perimenopause is a really interesting time. And that was what our episode was about, because that's something that we're getting a lot of questions about. Perimenopause is the time leading up to menopause, which can be up to 10 years. The average age of menopause in Canada is 51, which means that some people are actually going into perimenopause in their late 30s, early 40s, and starting to have these symptoms. But the symptoms can be difficult to sort of identify and diagnose. And also, I have to say, like, when we diagnose perimenopause, because women in general are not listened to and acknowledged in medical settings, these symptoms can be dismissed. And so my goal in sort of doing this, and I'm so glad that we're talking about it, is to clarify, like, when is it perimenopause? When are there options for support? Because it can be very confusing. And typically with perimenopause, what we're seeing is you might see cycle changes. So your periods might start to space out. They might get a little bit heavier. They might become lighter. And it's very different depending. Everyone's really unique in this journey. And then you might get accompanying symptoms. So you might have symptoms of breast tenderness 1 month, and then you might have vaginal changes as well. You might have the hot flashes and night sweats as we get closer to menopause itself. And again, these are things that can be sort of due to other things as well. And so our job as clinicians is to make sure, and not just say you're in perimenopause, but to really make sure that we're ruling out other things as well. And perimenopause is sort of seen as a diagnosis of exclusion after we've made sure that there's nothing else. So the things that we also have to make sure are it's not iron deficiency, it's not B12 deficiency, it's not your thyroid being off. Those are easy tests that we can test for. It's not sleep apnea. So sleep is universally a symptom that people struggle with in perimenopause because of hormonal fluctuations as well, but also the time of life that it is. And we also see emergence of things like sleep apnea and restless leg syndrome at this time of life. So we have to rule those things out as contributing factors. And then there's other things that can also be contributing, right? So it is a really important thing to say, like, could it be perimenopause? Yes. But it could also be these other things that we also need to address. So it's sort of a combined approach, which is why it sort of takes a little bit longer sometimes in these visits to really tease out what could be going on.
Yeah, I think that really is like a nice holistic approach to that question, because like you said, there are so many things that this could be. One question I had a lot of in my stories was about like joint symptoms and like body pain. So one specific one was whether plantar fasciitis can be a symptom associated with kind of midlife, perimenopause, menopause, and just like joint pain and musculoskeletal changes in particular.
Yeah, that's a great question. And so what's really interesting is that estrogen receptors are everywhere in your body. And the hallmark feature of menopause and perimenopause is fluctuating levels of the estrogen levels and progesterone levels as well. And estrogen receptors are also in your joints. And so some people do notice that when your estrogen levels, and perimenopause itself is a time that's sort of predictably unpredictable. It's a bit of a roller coaster is how I describe it to patients. And I draw it out for them too. I'm like, 1 month you might have higher levels of estrogen, 1 month you might have lower levels of estrogen, and it fluctuates and it's hard to predict, which is actually why we don't recommend necessarily doing blood work if you're at the right age, that we expect these things to happen because of that fluctuation doesn't give us a predictive value. Really,
I'm going to pause there because that's a big take home that I want to make sure that's driven home to the listeners. We talked about this in the last episode as well, but blood work is not valuable.
Yeah. So if you are over the age of 45 and you're noticing changes like period changes, hot flashes, night sweats, this is kind of the time that we actually expect that this might be happening because of the fluctuations in your hormones. And so doing that hormone test is not going to be that valuable.
Because it really depends on like when you measure it, right?
100%.
And it could be up or down one day versus the other. And it's like not something that you're going to guide management on.
No. And a lot of people, Shaz, and this is a big part of what we do on the podcast, is fight misinformation and try to support our listeners to know going and spending thousands of dollars on a test that's going to tell you if you're in perimenopause or menopause is not very helpful. So save your money, because if you do need those tests, those are covered by provincial health plans. And the times that you do need those tests to check your hormone levels, which specifically are your FSH, your follicle stimulating hormone, or your estradiol levels, are generally for folks who have symptoms earlier than expected. So early perimenopause, early menopause is considered under 45. Premature menopause or changes is under 40. Those individuals I do the testing for.
Right.
But those are covered under provincial health plans. But if I have a 47-year-old woman who's coming in and having these symptoms, testing their hormones is not going to matter. What actually matters is I'm listening to what you're telling me. I believe what you're telling me, that your symptoms are having impact, and we address the symptoms, not a number, because the number doesn't tell us very much. And it doesn't also tell us the severity of your symptoms, because some people at very high levels who have high circulating levels of estrogen, for example, may actually be quite symptomatic sometimes. And people with lower levels may not be. What we really need to ask our patients is, what are your symptoms? How is it affecting you? And then we can institute support.
Okay, so that's really great context. I know I kind of took you down a rabbit hole of the lab test piece, but let's get back to that joint and MSK question, because I know that's a question that I had as well.
Yeah. So we may start. So what people start to notice sometimes is that they develop joint pain that they didn't have before. So they might notice that they're a little bit more sensitive after a workout. They start to develop things like frozen shoulder or plantar fasciitis, or those kinds of symptoms when before it didn't really affect them prior to this time.
Mm.
That might very well be due to decreasing levels of estrogen. It could also be the wear and tear of aging, which we also see. And I think sometimes that's a big distinguishing feature. Like as we're aging, we're also going to be having some of these symptoms happen.
Right.
And so, but it's tricky to distinguish. Right now, at this time, menopause hormonal therapy is not indicated for joint pain.
Okay.
But it is something that's sort of like a yellow flag indication. So there's certainly like the green flag reasons why we would treat. And we're going to get to hormone therapy in a bit. And we'll get into a little bit more nitty gritty of why we might be treating symptoms or not and when hormone therapy is indicated. But some people, when I have a conversation, it might be another reason why we'll see, does your joint pain get better with treatment? And so, and I have many patients anecdotally who do get better with their joint pain when we do support the hormone levels or stabilize the hormone levels at least.
Okay, so it is kind of a known symptom like joint
It is a known
pains.
symptom.
It's not an indication for HRT, but people will kind of experience improvement with these symptoms.
They can experience
when they have
improvement.
HRT for other reasons.
Yeah,
Okay,
it's not necessarily the reason why we start the hormone therapy, but many of my patients do notice benefit. So I had a patient this morning who called me and we were chatting about this and she goes, my knee pain that I was getting physio for and otherwise it was really interesting because when I started on the hormone therapy, the knee pain went away. Now that's an anecdote. That's not based. We have to have larger scale studies that show us that this is something that we see consistently to be able to recommend it as an indication, an official indication. But the International Society does recognize joint pain as a potential reason to start. So it's interesting. Every different society around the world has different reasons why hormone therapy is indicated. But right now in Canada, it's not listed as an indication.
Okay, what about weight gain? So many questions. I know I've asked you this question before as well, Sheila, and we have talked about this in our previous episodes as well with our exercise specialists that we talked to. So weight gain in midlife. Is perimenopause a cause of it? Why does it happen? And how can we mitigate that?
Yeah, so really it's considered to be a product of aging, not necessarily a product of perimenopause or menopause, that the weight distribution can change. What we do notice, so again, hormone therapy is not indicated for weight gain, but what happens is if you're experiencing other symptoms like the brain fog because you're tired, because you're not sleeping because of the hot flashes or night sweats that you're having, hormone therapy can be helpful to help your sleep, help your energy, and help you make better choices in terms of dietary change and exercise. And so that is what will help the body fat distribution changes that we often will notice during midlife. But hormone therapy itself is not used right now for weight gain changes in midlife.
Got it. Now, one of the things that you kind of mentioned off the top of the episode was that this has been something that's really dismissed over the last several decades. And I can't tell you the number of questions that I get, not only just in my DMs from people who I don't know, but even just from friends of mine, because they know I'm a doctor, they know I'm connected to you, and that they know that, we're kind of in this space with the podcast. So how can people advocate for themselves in talking about kind of menopause or perimenopause when their doctor maybe isn't so open to discussing it with them?
Yeah, that's a great question. I mean, I was one of those doctors too, because I was nervous to prescribe these medications or ask about it because that's how we were taught. And the truth is, Shaz, we're not taught this in medical school yet. And even now, even though there is this shift happening, we're still not talking about it. And we're trying to change that. So what I suggest to patients is a knowledgeable patient is a patient that can go in and get more of that visit. So preparing for your visit's really important. Knowing your symptoms. There's, and we're going to put this in the show notes. There's something called the MQ6, which is a questionnaire that was created by a Toronto-based family doctor, actually, that's used internationally now to identify the symptoms of perimenopause and menopause. And it gives you a tool that you can take in. Now, proactively, family doctors are able to send that to you, and we're doing that in our practice, but not every family doctor is doing this yet. There's that tool that you can use. Know your symptoms. Symptom trackers are helpful. The Menopause Foundation of Canada has a symptom tracker list that you can also print off and take into your doctor or nurse practitioner. And then going in informed about, I wonder if this is perimenopause, naming it. or menopause symptoms, like that's very helpful to us as providers to be able to support you. I was a clinical lead on a tool that we created here in Ontario called the Center for Effective Practice tool, which we'll also put in the show notes. It's a guide basically for family doctors and nurse practitioners. It's made by family doctors and nurse practitioners. You and I both know, Shaz, that when patients Google information and bring us stacks of paper, it's not our favorite thing, but this is a tool that is actually evidence-based and made for clinicians to do this care. And patients have been printing it off and taking it into their doctor and being able to get care. So
I love that.
And so it's so helpful. So we'll put it in the show notes. And that's something that is a tool that will be very helpful to our patients across the country. And the more we talk about this, I think we're going to see a shift in family docs and nurse practitioners doing this more and more.
Love it. Now, what about, so there are lots of, I mean, you touched a little bit on kind of the misinformation in the online space. Tell me more about what sort of caution people should have in this space. Because everybody, it really seems like, because I'm so glad this is being talked about a lot, and I'm so glad that women's health is finally getting the attention that it needs and deserves. But as we've talked about before, it also leaves the door open to people who just want to make a buck preying off of these vulnerabilities. And so what can people do to exercise caution in this area?
Yeah, that's a great question. There's so much money being made right now in the menopause world, like $1 billion industry right now. And so many supplements being sold, so many weighted vests being sold, so many like different products that are being sold to help you through these symptoms. And I think that's because we haven't done a great job in healthcare to support our patients through this time. So it's no fault of our patients and the public to look for answers somewhere to feel better, because people don't feel great at this time sometimes in their lives, and they just want to feel better. So they're looking for answers.
And they're often dismissed.
So this is where we need to do a better job to shift that and build back trust with our public to be able to provide this care, which is what we're doing with these tools. However, there's still a gap here. So if you're looking at information online, look and see, like, are people selling me a supplement? Because if they're selling you a supplement, they're profiting from that. The supplements that you get,
or selling you a
generic,
test,
or selling you a test, those are the things to look out for, or selling you a specialized diet or something. There's no specialized menopause diet. There's no specialized exercise plan for menopause. There are like the same things that are not very sexy to talk about, but work very well, that we talked about with Dr. Lauren recently on our exercise physiologist, that work. We just have to do small, achievable goals. And I think we have to recognize that there's a lot of profit to be made in this space. So look at the international societies, look at the Canadian Menopause Society, the Menopause Foundation of Canada. Those are trusted resources. Beyond that, I would just be really careful, again, because while there's this push to like support women to feel better, there's a lot of sales happening at the same time, and just have that awareness. And I have patients coming in and they've paid hundreds of dollars for supplements, and I'm like, the same supplements bought in a generic form are just as effective, and you don't have to pay the big price tag because it has like somebody who's selling its name on it. So just be careful about that.
Are there any supplements that do have evidence in menopause? So like, I mean, the things that come to mind are creatine. We've talked about that a little bit before with Dr. Lauren. Magnesium for sleep. Like, are there supplements that you can get over the counter that do actually have some solid evidence behind them in the perimenopause and menopause period?
Yeah. So the natural supplements that people are using a lot, like evening primrose oil, ginseng, those things don't have a lot of great evidence to support symptom relief. And so what I always tell my patients is like, if you want to use this, you can, but the natural medicines also have their own side effects, so be careful.
And they also interact with other medications.
I'm sure you're seeing those interactions in the emerge,
absolutely.
right? So the increased bleeding risk with some of these sorts of things can also happen. So some caution with supplements as well. I think also I would much rather my patients have evidence-based medication that is Health Canada approved, that is dosed appropriately. Those are the things that I'm looking at supporting you with. And I know how much you're getting. That's also important when we talk about compounded or bioidentical hormones, which is really a commercial term that's being used and thrown around and very expensive. In terms of supplements specifically that we know that help, vitamin D is something that we are mostly deficient in all over across Canada. So that's something that helps with bone density, because we know that bone density decreases by about 20% in the first 5 to 7 years of menopause, the menopause transition. If you're iron deficient, which many people are in perimenopause because the periods can become very heavy, iron supplementation can be helpful. Calcium, ideally you're getting it in your diet, but you might need to top it up. Going to osteoporosis.ca can be helpful to do a calcium calculator. Apart from that, magnesium has mixed reviews. I know many people use it for sleep support. not seen to be really harmful, but it can have some bowel effects. Creatine is useful if you are weight training.
Right.
But beyond that, it's sold a lot for brain fog and otherwise. The data's out right now on that, so we're still waiting to learn more.
Got it. What about these private clinics that are popping up? So there are lots of clinics that are popping up like online and certainly in person, like kind of brick and mortar clinics as well as virtual care clinics that provide menopause care. Tell us about those.
Yeah, so this is filling a gap because, again, people have been dismissed, turned away, so people are looking for answers, and there have been the move in of the private clinics to do that. Again, I don't fault anybody for attending those clinics. They are well-intentioned, I think. However, they are charging large amounts of money sometimes. So
like
anywhere
thousands
from
of dollars.
Thousands of dollars for a visit, $500 a visit. That if that works for you, fine, but it's not the only way that we're going to democratize access to menopause care is by doing it in our public healthcare system, which is why these tools are important, so that more family doctors, more nurse practitioners you have covered care to reach the rural, remote areas, the patients that we aren't seeing. Like, this is why we need to actually have it in the public system and really safeguard our public healthcare system to make sure that everyone is able to access this care. The private clinics are serving their purpose, but again, they're so expensive. And I use a cautionary note because the private clinics, especially the ones that are compounding hormones, they're charging a lot of money for that.
Yeah.
And again, like, ideally, people are going to be prescribing you Health Canada approved medications because we have evidence behind that. We know how much you're getting. So use some caution in those situations when people say, well, they're really personalizing the hormone levels to me. We know, again, like, some people, again, like I mentioned up front, higher levels of hormones don't necessarily mean symptom relief. We really have to base this on how your symptoms are over time with intervention, not just a number.
Yeah, and I really like your point about the needing to have access in the public system, because if we don't advocate for that, and if we don't advocate for the inclusion of like billing codes or being appropriately remunerated as physicians providing menopause care in the public system, then there's no impetus for governments to fund that and to do that.
100%.
And like in this weird way, the private clinics are like decreasing that impetus to do that because, well, hey, you have access to this, but as you said, not everybody has that level of access because there is that barrier of having to pay. So I'm glad that you mentioned that.
Yeah.
Okay, so as we kind of shift into the HRT piece, before I ask you about all of those questions, I had a few questions about IUDs. So like the hormonal IUDs in particular. So the Marine IUD would be an example of that. And so the theme of the questions that came up were, how will people know that they're in perimenopause or menopause? And can they know if they have a hormonal IUD?
Yeah, that's a great question because the hallmark feature of perimenopause is really changing periods, but we're recognizing more and more that we also look at the other symptoms as well that people can have. So when someone has a hormonal IUD, like the Mirena IUD, often you don't have periods at all, or you just have a little bit of spotting intermittently. And it's one of my favorite tools to use because it decreases the heavy bleeding that can happen during perimenopause. Some people get
so you use it as a treatment for perimenopause.
I use it as a treatment for perimenopause because it levels out it stabilizes the lining of the uterus, the blood lining that we shed once a month. And it can be a treatment. It's also preventative for endometrial cancer, and it supports iron deficiency, right? Because you're decreasing your bleeding. So it's an excellent tool that I use often in my practice in perimenopause. The other tool that I use in perimenopause is the birth control pill. And we need to rebrand the birth control pill because it's not for birth control that we're using it. We're actually in perimenopause, again, because of that roller coaster of hormones that happens. The birth control pill or contraceptive pills, low dose, can level out the hormones really well. And that's what we actually want to do in perimenopause, is to help you level out the hormones from those fluctuations, because that's where those symptoms come in. So if somebody's on the pill or has an IUD, they may not get periods. And that's hard to then predict. Am I in perimenopause or menopause? So the trick is, do you have other symptoms? So you might still get hot flashes. Are you getting vaginal dryness? Are you getting the mood changes, brain fog? Then it might be that you're having those symptoms. If you are on the pill, technically you shouldn't be having symptoms because we are giving you
you're like replacing the hormones.
We're replacing the hormones. And a clear distinction, Shaz, that I want to really point out for our listeners is the pill, like low dose contraceptive pills, are actually a much higher estrogen and progesterone load than menopause hormone therapy levels.
Oh, that's okay. I didn't know that. That's interesting.
Yeah, and that's a
Okay.
big point because if you aren't able to be on the pill, like a combined estrogen and progesterone pill, because you have migraine with aura, you have a smoking history, you have a clot history, you may actually be able to still be on menopause hormonal therapy because it is a much lower dose of estrogen. And so that's a clear distinction that patients will come in and say, like, I have a history of migraine with aura, I'm never going to be able to be on hormone therapy. I'm like, actually, no, that's not a contraindication or a reason why you cannot be on hormone therapy versus you cannot be on the pill, but you might be able to be on hormone therapy. So if
Awesome.
somebody is on the pill, they're not getting periods, sometimes when they hit the age of 50, 51, we hold the pill for a little bit to see if they get a period back, or we do their blood work at that stage to see if they don't get a period back. That is another reason why we do blood work. And then we see if you're in to stage things out. But otherwise, it's kind of based on your symptoms and stopping and then checking.
All right, so let's dive into the topic that I had the most questions about, and that's HRT or hormone replacement therapy. So I have a bunch of questions here, Sheila, and I'm just going to dive right in. So tell me, like, what is HRT and what symptoms is it actually trying to treat?
So first off, it's what's interesting, Shaz. Like I think HRT is a term that we still continue to use, but it is sort of fallen out of favor because what the term is that we use now is called menopause hormone therapy, or MHT, which is like the artist formerly known as HRT is MHT. And so this is the reason why is that we used to sort of replace hormone therapy levels to what you were premenopausally, like in your 20s and 30s. Now we're not replacing to that full level. The only time we replace to the full level is if you have something called early menopause or premature menopause. So under age 45 or under age 40, then we are giving you replacement levels of hormone therapy because there's bone density protection measures and heart protection for those folks who go into menopause early. For other people, we're actually just giving you a little top up, but not to the replacement levels. So now
so
the
just
term
enough
is
to like
menopause hormone.
manage the symptoms essentially.
Exactly.
Got it.
Exactly.
Okay, so MHT, got it. So MHT, what are the indications for it and what symptoms is it trying to mitigate?
Yeah, so MHT, there's two different categories of it. So MHT, when we speak of it, we're talking about estrogen and progesterone therapies. And there's systemic, so full body hormone therapy, and then local therapy, which is generally what we reserve for the vaginal and bladder symptoms. So first off, the systemic hormonal therapy is estrogen and progesterone. Progesterone is required because if you have a uterus still, you need to have the balance of estrogen and progesterone to decrease the risk of uterine cancer, basically. If you don't have a uterus because you've had surgery, you can just have estrogen. And the reason why we use that type of therapy and that systemic full body hormone therapy comes in the form of transdermal, so skin absorbed options, which are the gel or the patch. And then there's also then the oral formulation, so tablets.
Like a pill.
There's pills, patches, or gels. That's systemic hormonal therapy, which is full body hormonal therapy. And that specifically, the indications for use of hormone therapy are very specific in Canada. So we use it specifically for treatment of hot flashes and night sweats, osteoporosis prevention, and then we sometimes will use it to help with sleep support and mood. So with systemic hormonal therapy, we know that there's a window of opportunity. And specifically, we know that it's safe to consider this for the majority of people. If we start it within 10 years of going into menopause or perimenopause, you can also start it, or under the age of 60. Beyond that time, we start to there's increased risks just by aging of heart disease risk, stroke risk, and clot risk. And so for that reason, we tend to use some caution if we're starting hormone therapy after that age. Previously, we used to say 5 years, you'd be on treatment, and then we have to stop you. But now there is no end date. We just have to continue to see you regularly and make sure that your heart disease risk factors are managed. And there's no other reason why you need to stop. So the only reasons we stop systemic or full body hormone therapy is if a patient tells us they want to stop. If they develop a reason not to be on hormonal therapy, those are the two main reasons why we would stop them. There's no 5 year and out rule anymore.
Okay, and so that's all the systemic things that we talked about. That's going to be affecting the whole body. Now, you mentioned local hormone options. I suspect that that's for like the urinary symptoms and the bladder symptoms. Is that correct?
Correct. So
so tell us more about those symptoms. Yeah. And then also what the kind of local options are.
Yeah, so there's a syndrome called the genitourinary syndrome of menopause, which is basically because, again, the estrogen receptors are very rich in the vagina and the bladder, the pelvic floor. And so at that stage, what we start to see are symptoms related to vaginal dryness, discomfort with intercourse or intimacy. It can just be uncomfortable for some of my patients say that it's even uncomfortable just to wear like pants that might chafe a little bit because it's uncomfortable. Then they can also get bladder symptoms. So urinary frequency, bladder infections, and incontinence. And so that spectrum of symptoms falls under the umbrella term of genitourinary syndrome of menopause. And that is a different treatment. So people who are on systemic hormonal therapy, many will see benefit in the vagina and the bladder. Some, though, about 25% of folks who are on the full body hormone therapy also need local estrogen therapy. And that is a local vaginal estrogen therapy that is in a pill form or an insert or a cream. The good news on the local estrogen therapy front is that it can be used at any age. So my patients who come in and they're experiencing bladder infections or incontinence, that is a time where I'm like, and if they're 70 or 80, I can safely start them on the vaginal estrogen treatment without an issue because it's considered to be safe because it's so low dose and locally absorbed. Also important are my patients who can't be on systemic hormonal therapy, like my patients who may have a history of cancer that's estrogen receptor positive. They can actually be safely on a local vaginal estrogen treatment, which is a very big, like there's been a lot of randomized control studies now looking at that specific population. And we know that it's actually safe and a game changer. Vaginal estrogen therapy is life-saving. You see it all the time, Shaz, with bladder infections that can turn into sepsis in the hospital and can lead to death. And if we actually treat the root cause, vaginal estrogen helps the microbiome. Because when we actually go through menopause, the microbiome changes, the bacteria changes from Gardnerella bacteria to E. coli. E. coli is the big culprit for UTIs.
Yep. Certainly what I'm seeing in the emerge is like that's a very common bacteria that causes UTIs and then that kind of more systemic
100%.
sepsis that can be life-threatening.
So this is where if we can treat the root cause of vaginal symptoms, and again, often my patients will be like, Dr. Sheila, I'm not sexually active. I don't need to be on hormone therapy like vaginally. I'm like, but what about your bladder health? And that is the way that we can treat. And when I give out a prescription for this, there is absolutely no end date for this type of therapy. We can start at any age. And when I give my patients a prescription, I say, this is till death do you part. Because while the other symptoms of menopause can resolve on their own, brain fog, hot flashes, night sweats, vaginal symptoms and bladder symptoms will continue to get worse unless we intervene.
Okay, so you mentioned that this could be something that's an option for people who have risk factors for cancer or have existing cancer. Now, the question that we still get, and I got a ton of, is does MHT cause cancer?
So no. So this is a good question. We know that MHT, if after 5 years, the older formulations that we used to use that we don't really use as much anymore because we have newer, better options. In the studies that were done, it does show a slight uptick in breast cancer risk of 1 in 1,000 more cases after the 5-year mark of use. So that's an important consideration. And how I frame that for my patients is I say, listen, it's similar to if you were to have a glass of wine every day. That's the same risk equivalency. If you were to not have a very active lifestyle, so if you're more sedentary, that's also a risk factor for cancer. So I kind of frame it in that way because it helps to kind of clarify, well, if I'm having a glass of wine every day or I smoke cigarettes, which is like a higher risk, then the risk of hormone therapy is actually on par with those risks, not with smoking risk. Smoking is much higher. So that's kind of the risk. The other risk kind of tend to, as I mentioned before, with aging, the heart disease risks and otherwise, over the age of 60 is what we worry about, which is why if you're on hormone therapy after that age, we just need to do our yearly follow-up to check your cholesterol, check your blood pressure, check your blood sugar, and just make sure that we're managing those things. Because beyond hot flashes and otherwise, menopause and midlife is a time where we see an increase in the heart disease risk factors, and we need to manage that and address those as well alongside the symptom management.
Love it. Okay, so last question for you. Other than HR or MHT, see, I'm going to have to, it's good. It's a good reminder for me to change it. Yeah, no, that's good. So other than MHT, what else can be done to support and mitigate perimenopause and menopause symptoms?
Yeah, great question. We always talk about lifestyle as well as a first step. So looking at what you're doing in everyday life. So alcohol use is a big one, Shaz. So we talked about this. We had an alcohol episode. So I encourage everyone to take a listen to that and why we encourage people to decrease use if they can. We know that regular alcohol use can affect our sleep. It can affect our energy. And it can also increase the hot flashes for people. So reducing that in your life can also help with symptoms. Smoking also can increase hot flashes. So decreasing smoking or smoking cessation completely can also be helpful. Looking at your diet, trying to, a Mediterranean diet's really nice. Having good fiber sources in your diet can be helpful as well. So 25 to 30 grams a day, if you can aim for that. Gradually building up to that number can be helpful for cholesterol, but also weight management. It helps you feel full longer. Protein in your diet's important. We talked with Lauren about that as well in terms of the amounts, just sort of looking at your meals and making sure. protecting your bone health, making sure calcium and vitamin D are on board, and doing strength training exercises for bone density protection. And then always, 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 like, especially in perimenopause, sleep is such a hallmark feature that gets thrown off. Like, I would say universally, I'm perimenopausal myself, like, and all my girlfriends are too. And sleep is the biggest issue that we talk about. And that is the hallmark feature of perimenopause that we really need to address. So looking at sleep hygiene specifically, sleeping at the same time, decreasing screen times. We had a great sleep episode actually for season 1. I encourage everyone to listen to that. It was fantastic. And then looking at specifically something called cognitive behavioral therapy for sleep or insomnia. That's a validated tool that is a short course of therapy sessions that really help with sleep support as well. So there's a lot of things that we can do with lifestyle that make a big difference separate from hormonal therapy. And if patients aren't able to be on hormonal therapy or they don't want to be on hormonal therapy, we also have excellent non-hormonal therapeutic options that can be used. And there's newer agents that have just come out that are game changing right now for those who can't take full body hormone therapy. We have newer agents that have just come out that are very, very effective for hot flashes. They're very expensive right now. So hopefully over time that price point will decrease, but it is an option.
Love it. Okay. So Sheila, this has been so great. Thank you so much for taking the time to answer all of these listener questions. I mean, I feel like we could do an entire other episode on this. Maybe we'll look at that for season 3. I think we should probably just do like one per season just to kind of keep everybody up to date on this, because it is such a hot topic and certainly one that everybody, myself included, really, really wants to make sure that we have evidence-based, reliable information on. So thanks for doing this with us today.
I'm thrilled. I think the main message for people is that you don't have to suffer through this time. Like, we have options to support you. So take a peek at our show notes for the resources that we shared, because then you can learn about them, learn about yourself. And it's a validating experience to know that you're not alone experiencing this and there's help available.
And thank you to everyone for tuning into the Doc Talk podcast today. A reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs. And of course, make sure to follow us on social media at the Doc Talk Pod and like and subscribe, and please review, because then that helps us reach so many more people with this awesome information.